a dentist. So Dr. Paul is a family medicine physician, has worked for more than 40 years in this field, and is one of our most dedicated physicians in our cohort. And we're very proud to have him always ready and willing to help us. I think I've given a brief introduction without much ado or taking a lot of your time. I will give the floor to Dr. Paul. Thank you so much.
Well, thank you so much for having me. Thank you for the lovely introduction. Before I start, this topic was one that was suggested by one of our participants at the last talk. Please, for everybody listening, if you have an idea of what you would like for a talk, we want to make these talks the most valuable for your needs. And if you can give us a suggestion, that's why we're talking about dental care for primary care providers. So into the chat, if you have an idea, please, we will definitely make sure we provide talks on the areas that you want. And the purpose of this is, I'm a family doctor, and I had patients all the time come to see me with dental issues. So this is sort of the basics for primary care. We're not dentists, but we're seeing problems, and sometimes in areas where patients cannot get to a dentist, where it's something that we can easily help. So if I could have the next slide, please. Okay, this is just general information. If you look at Kenya, care for oral cancers, infected teeth, periodontitis, is very prevalent, but unfortunately, without a lot of providers there to help, it's underaddressed. And usually most people come in Kenya, as in the United States, where I happen to be, to their primary care for a problem. They don't necessarily go to a dentist. So as a doc, what is your or a healthcare provider's? One, you want to know that something in the mouth can be an indication that the patient has disease outside the mouth. It's just a manifestation. It's an indication of a disease affecting the body. Two, you want to start treatment in an appropriate fashion, choosing the right drugs. You want to make sure that what we give our patients obviously is safe and hopefully effective. And then the other critical part is to look at something and say, we need, or you need for your patient, more care than I can give you because we're worried about a cancer, something that, obviously as a primary care doc, you want to recognize, but we're not going to necessarily be treating it. We're going to refer it. And then as part of our ongoing dialogue with the patient, besides talking with them about general health issues, we should give them information about preventing dental diseases and managing our oral health as appropriate, and also given the limitations that the patient may have. So that's where, we as providers fit into this whole picture. Next slide, please. Okay, so some diseases are linked to a chronic disease, but they come with a problem in that the patient's going to say, I have a problem with my mouth, with my teeth. Next slide, please. Diabetes. Very important disease for us to recognize. One, if you have periodontitis, the inflammation, dry mouth, keep getting yeast infections, like candidiasis in our mouth. If after a patient has had a tooth removed, it's not healing. They say, hey, I was at a dentist, he pulled a tooth, and that was a little while ago. It's just not getting better. Or I've got a burning sensation in my mouth. We should think about this patient has not only a local problem, which we're going to treat, but could they be diabetic? And that is, so we are helping the patient not only with their initial problem, but also we're looking into a problem that we would be responsible for treating their diabetes. And I assume that, maybe I'm wrong, we all know that we want to get an A1C less than 7%. Now, I don't know how easy it is to get an A1C in all parts of Kenya, but hopefully you can get a simple blood sugar. And if you get a fasting blood sugar, unfortunately, I'm using American numbers and I don't have the international numbers because I've been doing it too long. But if you know the normal numbers, it would be 100 in milligrams in my uh, notation, but less than 7% A1C. Here's how you do for the oral yeast infection, fluconazole, or one of the others. Ideally, somebody can brush their teeth twice a day with a fluoride-based toothpaste. I don't know what's available to your patients. Brushing your teeth is important and telling them to do it twice a day with toothpaste ideally, but even if they don't, just the brushing your teeth. Ideally, you can see a dentist every 6 months. That's a great concept. It may not be available in all parts of Kenya. I can tell you in the States, there are some places where dental care is lacking. And the other question or the other part is poor diabetes control can worsen conditions. So the other thing, if you want to look at, if you have a patient who comes in, and this is this last note at the bottom of the page here, if you have a patient that comes in who's not a well-controlled diabetic, and they say, I've got this tooth in my mouth which has just been bothering me, and I've done everything, I've taken the medicine you've given me, and it's getting worse. If their diabetes is not well controlled, they're at risk for having a procedure for complications. So it's our obligation, if we're managing the diabetes, not only to help them over that period of time and for the pain and the maybe infection for their dental problem, but to get their diabetes in better control so they can safely have a procedure to work with. Now, I don't know if any primary care providers in Kenya do dental extractions. I know in the States, in rural area, there are some doctors that do that. I don't know about Kenya. Next slide, please. HIV/AIDS, worldwide problem, and it can have dental implications. And if you look at these 4 slides, and by the way, all of these slides are available to you. And with your email, Anthony can send all this out to you, so you don't need to worry. If you're taking notes, it's all available. But there are associated dental problems with HIV. And we should keep that, those of us who do treat patients with HIV, this has got to be in the back of our minds when a patient comes in, we're following up on their HIV, they're a new patient that presents, and if we may not know their HIV status, but if they come in with the hairy leukoplakia, which is at the top of the screen, in the back of your mind, you say, you know what, maybe I should look at their HIV status. And I don't know, I would imagine that all of us ask our patients for their HIV risk, but this would be something else again to trigger that or to do the test. Because somebody who has HIV may not know early on that they're positive. So again, the sarcoma that's mentioned on the bottom, that's suggestive that our HIV is progressing. And you've got to do an urgent referral for a biopsy to get that information. So again, here's a condition, very important condition worldwide, but it does have oral manifestations. And the patients may not have gone to a dentist. They're going to show up for you first. And you've got the opportunity not only to treat this and do the referral, but to make the diagnosis. And then, as Anthony mentioned before, because the Addis Clinic does help folks with HIV, we can get them help. Next slide, please, Anthony. Pregnancy. Okay, there are dental changes in pregnancy. And that is important to know. I'm sure a lot of the providers here manage patients who are pregnant, and you've got to be aware of the dental conditions that come, the changes that come in pregnancy. You can get easily bleeding, as it says, the gingivitis. You can have overgrowth, which can go away naturally. You get an increased risk of infection, the caries, the dental problems due to the dietary changes, morning sickness that unfortunately some women experience. And also when the woman who's pregnant comes in, when as you're checking her blood pressure and looking for, checking her urine for protein and looking for edema in her legs, don't forget oral hygiene. That's something that's really easy to reinforce because sometimes after we leave a visit, all of us and our provider has given us information. We don't remember everything. And a lot of us, don't we provide something in writing to the patient? Please do A, B, and C. You give your patient the good advice, but do it the next visit when she's pregnant and comes in and the following visit. Also, avoid, if that patient has an infection, tetracyclines, and that's in safe primary care, avoid tetracycline. It can stain the infant teeth, the fetal teeth, and it can make a difference during the third trimester. Don't do x-rays or suggest an x-ray if a patient is pregnant. Just the risk of radiation. Again, just the dental part of pregnancy care. Next, please. Okay, leukemia and other blood diseases. What you can get with acute leukemia are changes in the mouth, spontaneously bleeding. It's not just a little bleeding if you're too aggressively brushing your teeth and you happen to scrape your gum. This comes almost by itself. If there's overgrowth, you get other petechiae, these little spots in the mouth, ulcers, pallor in the mouth, making us think of anemia. So if you see a patient with these things, what should we do? Do some blood work. If you are a primary care provider, you don't want to do a dental procedure until you know what their hematological, their blood status is. And you may want to, depending on the results, you can refer this patient to a hematologist. So the patient that came into you and said, my gums just keep bleeding and I'm not brushing my teeth. I haven't eaten something that is harsh or, and I'm bleeding. Our responsibility, do the necessary investigation, the CBC, which is easy. And then if that comes back with a change, do the referral. And if you look at in the final, which is sort of the most important, somebody comes in with spontaneous bleeding, they've got pallor, they're tired, do that workup before you do anything else. If they have an infection in their mouth, sure, treat that, but don't do anything more aggressive until you do the rest of the workup. Now, if that workup comes back and they just happen to they're pale and all the CBC is normal, okay, you can go on. This is not that everybody who is pale with some bleeding and is fatigued has leukemia or another blood disease, but we've got to look for it. Next again, please, Anthony. Okay. Look at the other conditions which have oral manifestations. Chronic kidney disease. And for chronic kidney disease, that we're going to avoid the non-steroidal anti-inflammatory drugs for them. We're going to avoid the tetracycline type antibiotics. We're going to be cautious with the use of paracetamol for pain. If they got hypertension, amlodipine, nifedipine can cause problems in up to 20% of people who have them. So if you've got somebody who's hypertensive, You appropriately started them on amlodipine or nifedipine, and their blood pressure is well controlled, but they come back to you and they say, I've got swelling in my gums. Um, Maybe the cause of that is the medicine we chose, and they're one of that 20%. We can switch them to another agent and treat the condition. Again, an oral manifestation, in this case, of a side effect of a class of drugs. If they're epileptics, and I don't know the medicine that is commonly used in Kenya, and I'm sorry for my lack of knowledge, I'm trying to gain more. Phenytoin can cause the hyperplasia in 50% of patients. That's a huge percentage. How many drugs cause a problem in 50% of the time that you give it to a patient? If that is the drug that is the best control for your patient, then we've got to counsel. Our responsibility is to counsel, give guidance to that patient. You're on a medicine, we're controlling your seizures, but this medicine can cause you problems in your mouth. This is what you have to do to prevent the problems. So if you have to use that drug, there's a solution. If there's an alternative, if the patient has done everything and you can switch them to another option, then you can consider valproate or one of the other drugs. And also, of course, a seizure when somebody falls, they can fracture their teeth, unfortunately, as one of the consequences. Look at GI reflux. How common is that in your patients? Here in the US, very common problem. So you want to, if somebody comes in and you see erosion of the palatal surfaces in the upper teeth especially, one, tell the patient, if you've been sick to your stomach and you've had reflux, rinse your mouth first. Don't go and brush your teeth right away. Manage the underlying reflex. And interesting enough, and I know we're talking about dental problems, one of the easiest ways of managing reflux is have the patient sleep with their head and the upper body elevated a little bit. That just uses gravity to keep the acid in the stomach and help stopping it from going up through the incompetent sphincter between the esophagus and the stomach. No medication, and that simple treatment. Another way of doing that is at the head of their bed, not under the pillow, but under the actual bed. Raise it, 10 or 12 millimeters, or even more, 20 millimeters up, a piece of wood, some type of stone, just to raise the head of the bed so acid stays in the stomach. Unrelated to dental, but that is, the reaction is to keep that acid out of going up into the mouth. Next slide, please. Okay, so how do we identify something? Patient comes in and we're looking for dental problems. As part of our exam, for less than 2 minutes, you can look in the mouth, do as part of your general physical, especially patients who have chronic illness, hypertension, diabetes, HIV, TB, all our patients who can be immunosuppressed, or if they come in and they say, I'm just not feeling well, and we're not putting it together. They're not, it's not that they've developed pneumonia and they have the cough and that's it. But if we've got these unexplained generalized symptoms, take a look in their mouth. Besides, we're obviously going to listen to their heart and lungs and feel their abdomen. Make sure we check their mouths. Simple thing to do, can give us a lot of information. Next, please. Okay, let's do the oral exam. Your lips and your skin. You look at the mucosa, you check the tongue, and the palate and the oral pharynx. And if you're like we all get into a pattern, and if this becomes your pattern, you're not going to miss anything. Use a light to make sure that you're a pen light, not just the room light, gives you better illumination. And if you see something, make sure that you document it. So if you're seeing something in the patient now and it's a little concerning, and you tell the patient, I'd like you to come back in a month, you've got a good note to compare it. Because if you ask me for a lesion on a patient's tongue, what it was like when I saw them a month ago, unless I have a good note, I'm not going to remember, and I don't think I'm unique. But if you made a note, this is the size, the shape, the color, the change, and you look at it again down the road, great, you can make a good comparison. Now, if the patient comes in and they said, they're using the time frame of 3 weeks, 3, 4 weeks, or longer, depending on how frequently patients visit you, and you look at it and you find something and you don't have an easy answer for it, and if you can do a referral, that's appropriate. Next, please. Okay, so what are the common things you're going to see? Dental caries, and people come with a toothache. They say, when I eat something cold or warm, I'm aware of it. There's something that, and it's easy to change. If you give them a Tylenol, you can do it, but sometimes you need a dental referral depending on what you sound. A dental abscess, swelling, localized pain, sometimes fever, it can spread. You want to use an antibiotic. And depending on how severe it is and your assessment of the patient, you may need a more urgent dental referral if that's available. Obviously, if they're having trouble breathing, that's an emergency referral and transfer to an appropriate facility. And again, I know some places that's really difficult for patients to get to, but we do the best we can. If you come in, they're bleeding, their gums, they have bad breath. This could be due to a generalized disease. You still give them information on brushing their teeth, on using an appropriate rinse in their mouth. And if possible, with the periodontitis, you could refer them for appropriate dental care. May or may not be available. And then the ulcers in the mouth, if they're yellow or red, less than 1 centimeter, they can usually heal with topical steroid, a triamcinolone paste, a mouthwash. If it keeps coming back, look for that generalized condition. There's somebody else in their body that is causing this. Next, please. Okay, what about medicines? What medicines, when we use medicines, affect in primary care, because we're using such a wide spectrum of medicine, which ones should we use in a basis, a more frequent basis to help with our patients? Next slide, please. Okay, here are the medicines. Please I don't need to repeat these. Please get the slides. They're all listed, an indication of why we should use it, a dose, and with food, without food, the length of time, and the notes. For example, just using paracetamol, that's first line. It's safe in pregnancy. But if somebody has liver disease, we're going to be cautious about it. Ibuprofen, third trimester, you're going to avoid. And it goes down for the rest. So, this is important for us to have, and sometimes just to have often a little card on the side just to remind us when we're treating dental infections. Next slide, please. Okay, what medicines can cause problems? So not only are the medicines that we're using, but if you look at dry mouth, the amitriptyline, antipsychotics, diuretics, antihypertensives. And here's what you do. Our patient may need, obviously, an antihypertensive. We're not going to avoid it, but when we tell the patient, when we give the medicine, you may get a dry mouth when I give you this medicine. I suggest you take frequent sips of water if you can. If you're going to take gum, without sugar, if possible. If there's a fluoride toothpaste available, you know, so that's, and use the lowest effective dose. Obviously, we do that for any meds. Overgrowth in the gingiva. Again, nifedipine and lodipine. And then biphosphonates can cause osteoporosis. So if you have a patient with osteoporosis, you've got to be realizing that can make a difference for that patient. And especially if they go and have a referral. So if you're sending that patient to a dentist who's osteoporosis, make sure you tell the dentist what they're on, so that because the patient may not remember the name or the condition, or forget to tell the dentist, hey, I'm on this drug. And this is something that is our responsibility to notify the people we refer patients to. And, you know, something which I'm sure we all do, with the final note, before we do anything, not only for any dental procedures, know what medicines our patients are on. Not only prescription medicine, supplements, herbal medicines, you know, any other remedy which they may be taking, not from you, but from either another provider, from a friend, from going into a local pharmacy. You know, that's important for us to know in all conditions, and especially, of course, in oral problems. Next, please. Okay, preferred antibiotics. These are the ones that we prefer to use in patients. The amoxicillin, first-line infections. And now, if the patient is allergic to amoxicillin, erythromycin. And obviously, the last one, if they're resistant, if they're penicillin allergic, we can't use. And we would have to, again, try the erythromycin. What do we avoid? Tetracycline, ciprofloxacin, clindamycin, only if we have a risk of C. diff. There's a risk of C. diff, rather, but if they're penicillin allergic and other medicines are not suitable, clindamycin. And also, antibiotics without drainage, unless there's no option, try and do the definitive dental treatment if possible. Next, please. Okay, what are oral lesions that require urgent concern? Cancer. And we can be the first line source. And any new oral lesion beyond 3 weeks without a clear explanation requires further workup. Next, please. Okay, and here are what we call the red flags. And I'm not, you can read this as well as I can. A suspicious mass, fixed, hard, irregular, swelling of the tongue, the floor of the mouth, the jaw. Once you see that, you're going to check their neck. If there are any lymphadenopathy, are they experiencing numbness? This is really important. If you have an ulcer, which is, they said, you know, I've had this ulcer, it's been there for more than 3 or 4 weeks, especially on the lateral part of our tongue or the floor of the mouth. It's cancer until we prove otherwise. And in Kenya, which is like other tobacco, the use of cat, alcohol, the betel nut, oral hygiene, HIV, all these other are risk factors. Our patient is more susceptible if they have a risk factor. And when we are seeing the patient, we should be asking them about, you know, are they a smoker? Do they use cat? In a non-judgmental way, of course. We need that information to help them. Next, please. Okay. And here's just a simple slide that says, how do we know if something's benign or concerning? Length of time, painful, a clear cause, and it starts to heal versus longer period can be painless. That cancer can definitely be painless. It's unexplained. There's some numbness, and it's not responding to treatment. So if we delay a referral because we're not sure if it looks benign, it's important. If we delay a referral for cancer, that's important. Okay, next slide. I think we're okay. And then emergency referrals. And this is easy. Compromised airway, we think we have cancer, a severe infection, and uncontrolled bleeding. If any of us see this in a patient and we're not able to handle it, and that patient needs to be referred. And of course, that would be even not only for dental. If you come up with a patient who's got a compromised airway, we're going to refer them and start treating them. Next, please. Okay. And again, here's just a review. You'll have all the slides. Airway compromise, how can that help happen? You got submandibular swelling, elevation of the floor of the mouth. If possible, try and make the airway as accessible as possible. Spreading infection around the neck, fever, swelling, trouble opening their mouths, trouble swallowing. If you see a patient or you try to do a dental extraction and they keep bleeding, you've got to, here's a partial solution with this soaked gauze, but also you have to think of, do they have liver disease, thrombocytopenia, some reason why they're not stopping to bleed, and you may need to refer them. And then, of course, the suspicious lesion, which we've talked about. Next slide. Okay. And again, we're going back just for a moment to what we give our patients. This is a summary for good oral eye hygiene. Ideally, fluoride toothpaste, but at least twice a day. A soft brush toothbrush, not firm, that's going to irritate your mouth. Try to clean your teeth daily if possible. Cut down the amount of sugar, which is good anyways. And if possible, a dental checkup. And I don't know the status of fluorinated water in Kenya. In the States, they're removing it, unfortunately. What to avoid: smoking, alcohol. Don't use your teeth to open something. Don't bite your nails with your teeth. Look at self-medication with traditional medicines. Can it affect our teeth? Don't share a toothbrush with somebody else, hopefully. And don't ignore dental pain. And this is what you can just gently mention to your patients when you're doing their visit. Next, please. Okay, and this is sort of a brief summary of what we've talked about. An exam, looking at other conditions that relate to oral hygiene, prescribing safely, looking for those conditions which are important to recognize because we're worried about they could indicate something more seriously, and educating our patients. Again, if you get this slide deck, it's all there for you. Thank you. And do we have any questions?
So for everyone, you can use the Q&A. We have 8 minutes for response. We have the Q&A, and I think we have 4 questions. First question, Dr. Paul. What do you advise on the mouthwash that we use every evening before sleeping?
I'm sorry, what's that? I'm having, it's not you, I'm having a little trouble with my speakers. I'm going to see if I can fix that. Hold on. Give me 1 second.
Okay.
That's better. I'm sorry. Oh, I just lost you. Where are you? I don't know why I
Can you hear
lost
me?
you. I just lost my Zoom.
I can see you. Can you hear me?
Can you see me?
Yeah, we can see you very well.
Okay, I can. Oh, here we are. Oh, it said get started. Open Zoom. Okay, we're back. I'm so sorry. Thank you. Okay, I'm sorry. What was that question
The
again,
question,
please?
the question is, what is your advice on the mouthwash that we use every evening before sleeping? Is it advisable?
I don't know what's available there, and I'm so sorry. Is that something that I could ask somebody there to try and research? Because I don't know what's available in Kenya. I'm sorry. I wish I could answer the
So,
question.
most mouthwash, there is the Listerine. The most common one is the Listerine mouthwash,
Right.
and most people use Listerine mouthwash
Good.
for
Yes. Okay. If you can
for
use
regular.
Listerine, that's great. That's a good mouthwash. If it's Listerine, if that's the same brand as in the US, that's super.
Yeah.
That's an excellent mouthwash.
So it's okay to use it on a daily basis.
Yes. Oh, for sure. Some on a twice a day basis if you want to, whatever, and it depends after some people do it after a meal when they feel that there's something,
Yeah.
it's affected their mouth. Definitely. Very safe.
Okay. Thank you. The next one is on teeth whitening. A lot of people have. There's a new trend of teeth whitening using acid-based uh, materials or anything they come across that is acid-based that does teeth whitening. Is it advisable?
I'm going to have to, I'm going to be sending you answers to some question. Honestly, it's not unique to Kenya. It's here in the States. I want to find out for you in a much more detailed answer the benefits other than cosmetic, if there are any, and the risks, and what conditions specifically, if a patient has, that they should avoid. Because, it may be okay if you're in good health, but I don't know if you're on certain medicines, have a underlying condition, if it makes a difference. I will get that back to you.
Okay.
Next, please. Thank you. Excellent question.
The third question is on: is it do you advocate for tonsillectomy in children if the tonsils are recurrent?
Uh, that is a really that question is hard to know. It used to be when I started my training, a kid had one or two bouts of tonsillitis, and we did a tonsillectomy. I believe, and again, I'll get that back to you. No, that is not indicated. You treat the bouts of tonsillitis, but you don't do the procedure. But I don't want to say that definitively till I look up the current status. Um, and let me ask, and I'll try. I don't know how easy is it in Kenya, outside the major centers, for a patient to get for a child to have a tonsillectomy? Is that difficult or easy? Do you know?
It's not easy because you have to book a physician or an ENT or a dentist to take care of it. So most of the cases you find mostly it has to be taken care of by a physician or an ENT specialist, a pediatric ENT specialist. In most cases, it is booked. It's a clinic that you have to book and wait for the physician to be available.
Okay, so I mean that was just for my knowledge. I will get back to you on at least the current guidelines for tonsillectomy in children. When is it indicated? At what point, and on what basis? And when is it not indicated? Which children are at higher risk for a tonsillectomy if they have, for whatever reasons, based on age, based on underlying problems, etc. Good questions. Next, please.
The last question is on there's a common trend by uh, uh, the periodontist and the dentist on advising extraction. And extraction of teeth rather than having root canal. Most of the time you find they don't advocate for root canal. What do you think? Because most people think that root
You're
canal is
asking,
being
you know
phased
what?
out.
I'm going to find out because, again, as a family doc, where I am, it's so easy to get dental care. I'm not faced with that, and I see it. But obviously, this is a very valid question. I will be sending you by the end of today, so you can distribute to all our viewers and the people who are asking these excellent questions an answer. And when I send the answers, I will make sure we have the reference that I'm using because what's important to know if you want to go back and look at that much more detailed answer than I'm able to give to see, how many children, if we're talking about doing a tonsillectomy, how many children did they base that answer on? How big was the study? Who are the people doing the study? Because then you can look and make a decision. Yes, this is a good study. I agree with it, or no, it isn't. And as an aside, that's something, if we can do it, we should do for a lot of recommendations because you want to make sure that our medical advice is well founded scientifically.
Thank you,
So,
Dr. Paul.
oh, my pleasure. But again, if there's anybody in the audience, please, who has a suggestion for our next talk, we have a few ideas and we're going to send them out to people and present them. But if there's anything that you think that we can do to help you, please let Anthony know, and he'll move it on to those of us who to work on the talks.
Yeah, Dr. Paul, I think there was a suggestion previously on wound care, and I
Right.
think I'll talk to Kinoti to be part of the presenters there and be with you for the next talk on wound care. And there was a suggestion too on interpretation of EKG, ECG, and all that. Hair fast, uh,
Oh, perfect.
early.
And the other talk, just to which we have been discussing, just to throw it out to the audience, AI is becoming really a
Yeah,
new part of medicine. If we had been talking 2 years ago and we've been talking about dental care or we've been talking about hypertension, AI would never have entered into that conversation. Now, at least in many places, AI is becoming used, but it's not a perfect instrument. There's nothing that's perfect. And we're talking about a talk to talk about what is AI, what is its place, what are the risks of AI? Yes, there are benefits, but what are the negatives that we should all be aware of so we just don't blindly use something that's a new tool and may not be appropriate for everybody.
I think Surface has a question. Hey,
Okay,
go ahead.
thank you very much. And this is excellent presentation, and it's very helpful because the dental care in primary care is very useful because most of us is working in rural area. So this is very important. I have some question. Actually, 2 days back, I have a patient with gastroesophageal reflux disease, which we call it GERD, and she was being treated with omeprazole, and in the middle she developed like a tonsil stone, which is visible, and I referred to the city for ENT specialist. So, Dr. Paul, is there any relation between the GERD and the tonsil stone? Uh, is she developed because of the gastroesophageal reflux disease? So one of my question is that.
I will, you know what, if you can, Anthony, if you can send me that question, let me research it to give you a appropriate answer, and we'll email it back to Anthony to send to you, if that's okay, please.
Thank you. That's okay.
Right. Oh, and
So
one other, something else, is omeprazole very commonly used now in Kenya?
Yeah,
uh,
very, very. In East Africa, in other, very. It's
yeah,
one of the most used PPI.
Okay.
yeah,
The Mayo Clinic here in the US, oh, this is 6 or old month data, have noticed that after 4 years of ongoing use of omeprazole, there's a 30% increase in the risk of dementia.
okay.
So what I've been doing and is with omeprazole limited its use. It's, when it came out, it was short-term use. You had gastritis, you had a gastric ulcer, you used it for a month or 2 months, and then you tapered the patient off it. If you stop it suddenly, you can get a rebound hyperacidity, and that's why patients will say, oh, gee, my problem's not over yet, and I go back on it. And then I often would move, sometimes you slowly decrease it, and you can move to an H2 blocker. Famotidine is one that we have available, which doesn't carry that risk. I mean, omeprazole is a great drug, but you don't want to be on it for years and years.
That is very important. That is a very good explanation, doctor. And while you are taking, when you talk about the famotidine, currently from Ethiopia, almost famotidine is becoming out of the market in most of the places. Do you have any information regarding that famotidine, especially almost 4 months back? We are told that we don't have to use cimetidine, especially intravenously, and from our health center, it's almost is not buying
Okay,
cimetidine. Do you know
let me find
anything
out.
regarding
Yeah,
that?
yeah, I will find out and get back to you. Just as an aside, I volunteered in Gondar about 3 or 4 times in Ethiopia, so I know I've had the pleasure of being there.
Thank you, thank you. The other question is, while we're treating when we found gingivitis, especially in primary health care in health centers, gingivitis with dental caries, we use like amoxicillin. After
Beautiful.
examination, we give amoxicillin. In addition to amoxicillin, we give metronidazole, TID, for 3 days, and then we send for the dental care specialist.
Oh yeah.
Could you add something on that, or we are correct in
No, that's
treating
excellent. You're doing excellent care. That's beautiful.
Okay. The last
Yeah,
question
and
being,
that's exactly what we were talking about. No, that's very appropriate.
okay. And the last question is that in Ethiopia, most of the people, even in big cities, use a short plant stick to have a dental care, like to clean. And most of them also prefer that plant, the short stick, rather than the toothpaste. By saying like that, the toothpaste, when we use repetitively, it can cause like a bad smell when we don't brush for 1 or 2 days. So it's
Yeah, yeah. The only I don't know enough about the stick. The only risk would be trauma to the mouth. Done properly, I'm sure it's safe and it's been done. I mean, this has been for how long in Ethiopia? For I'm sure a long, long time, and a lot of folks.
yeah. Thank you. The last suggestion is, if it is possible, my recommendation to the next topic, maybe STD, sexually transmitted disease, other than the HIV.
100%. That's easy to do. Thank you very much. It will be, I'll work with Anthony and the Holly, who's also here, and we will get a presentation, and obviously let you know about it on that topic. Thank you. It will be done.
Thank you very much. Have a nice time.
Thank you for your help, for your
Thank you,
comment.
Haya. Those are great.
Yeah, okay.
I think, Dr. Paul, there's no other question, and we are 8 minutes past time, but we appreciate the availability of everyone that joined us today. We'll give our executive director the room to adjourn the meeting for us.
Thank you, Anthony. Thank you, Paul. I think thank you for all the good questions to the participants. I think it was another great webinar in a topic that hasn't gotten as much time as it needs in its relations to other healthcare issues. So this was a really useful session. And again, we look forward to you joining us next time. And please keep sharing your ideas with you can write back to Anthony when he sends you the slides and suggest some topics for the future. Thanks, everyone. Have a great evening.
Thank you so much, everybody.
Thank you. Bye bye, everyone.